it gives me great pleasure to introduce Professor Brigitte Farou, who's a professor in pulmonology, and she's head of the Pediatric and Non-Invasive Ventilation and Sleep Unit at the Necker University Hospital in Paris, France. I think an interesting question is whether children may be weaned off CPAP or NIV, and I wondered if you could tell us your thoughts with regards to that question.
I think this is a very important pediatric specificity. We saw in the diagnostic group that nowadays the most important diagnostic group is represented by children with upper airway obstruction. Those children may improve spontaneously with age or may improve after several interventions like ENT, upper airway surgery, maxillofacial surgery, or in certain cases, neurosurgery. So I think that for those children, it is recommended to regularly evaluate the necessity to continue CPAP. So we made a study in our unit where we analyzed the diagnosis and also the weaning criteria in all children who were able to be weaned from CPAP or NIV over 1 year. First, we established the criteria that allowed us to wean those children from NIV or CPAP. We had first some major criteria, and the most important was a clinical criteria with disappearance of nocturnal and daytime symptoms of sleep disordered breathing after several nights sleeping without ventilatory support. So it's necessary to stop the CPAP or NIV at least several days because there is a long-lasting effect of long-term CPAP or NIV. Also, the child must have normal nocturnal gas exchange with spontaneous breathing and after having stopped CPAP or NIV for several nights. So pulse oximetry, transcutaneous CO2 should be normal, and if a sleep study is performed, the apnea-hypopnea index should be low, at least below 10 events per hour. Then we had also some minor criteria that included minimal SpO2, maximal SpO2, and so on. So here is our experience. So in our unit over 1 year, we had 58 children among the more than 250 that were on long-term CPAP or NIV that could be weaned from CPAP or NIV. So what you can see that the majority of children were treated with CPAP, which is explained by the underlying diagnosis, which is mostly upper airway obstruction. You see that the mean duration of CPAP was 1 year and of NIV 4 years. When you see the primary diagnosis of those children, you can see that the large majority of children had anatomical or functional obstruction of the upper airway with laryngeal pathology, Pierre-Robin syndrome, Prader-Willi, Treacher-Collins, and so on. And the reason for CPAP weaning was spontaneous improvement in nearly 60% of the children. We all know that children with Pierre-Robin syndrome improve with age. It's the same for children with achondroplasia, but also for children with bronchopulmonary dysplasia, for example. You can see that the majority of the other children, around 40%, could be weaned from CPAP after upper airway surgery, maxillofacial surgery, and in some rare cases, neurosurgery. So that means also that if you have a child with upper airway obstruction, it is necessary to evaluate the need to continue CPAP after a surgical intervention that aims to improve the caliber of the upper airways. So this slide, I think, is very important and gives an important message for the parents. Here you have represented some different diagnostic groups, in which the blue columns represent the age at onset of CPAP, and in red, the duration of CPAP. You can see that there are 4 diagnostic groups, 4 or 5, where CPAP is started very early in life. Pierre Robin, children with Pierre Robin have the maximum of airway obstruction between the age of 1 and 2 months. So they need to be, if they have severe obstructive apnea, they need CPAP very early in life. Same for children with Treacher-Collins syndrome, children with laryngomalacia or vocal cord paralysis, children with polymalformative syndrome and bronchopulmonary dysplasia. But then the mean duration of CPAP is quite short. Pierre Robin is very short, it's around 2 or 3 months, and it reaches almost 1 year in children with a laryngeal pathology or bronchopulmonary dysplasia. Then you have other diagnostic group where the CPAP is started at an older age because it can be promoted by hypertrophy of the adenoids or the tonsils. And you see that children with Prader-Willi achondroplasia or idiopathic obstructive sleep apnea may require CPAP at an older age, which a duration of CPAP that lasts between 1.5 and 3.5 years. So this is important for the parents also, because then you can tell approximately how long the CPAP treatment will be needed.
I think that's really good points. I think the first one, that often patients will come with their parents and say they had 1 night off or 2 nights off and they were absolutely fine. I'm going to take them off it. You've raised that actually it needs to be for a longer period of time because of the overlay of CPAP. And so that's really useful information. And the second point is, I know that parents always want to know if they're ever going to come off. And so the research that you've done gives, at least we can give them a trajectory. I've had only 1 neuromuscular patient ever come off NIV, and I just wondered whether you had seen any patients that you don't necessarily think would come off, but it has been possible in some instances.
Yes, most often in spinal muscular atrophy or Duchenne, it's a progressive aggravation of the respiratory muscle weakness. So those children will not be able to be weaned off NIV. However, there are some congenital myopathies where the children may improve sufficiently to be weaned from NIV. Of course, this is very, very rare, and it's quite exceptional.
I'd like to thank you very much for your contribution to our paediatric series of sharing practice with CPAP and NIV. Thank you so much for your time, and I'm sure all of the people watching will really appreciate the information that you've given them. Thank you.